Hello,
Hey, Stefania, how are you?
I'm good. How are you?
Excuse me, good. All right, so I'm going to go ahead and get started. So for PNR 208 Exam 3, it's going to cover the concepts from weeks 7, 8, and 9. So week 7 was infectious disease prevention and control, HIV, tuberculosis, and your sexually transmitted diseases, bioterrorism, and disasters. Chapter 8 was home care, community resources, case management, and then care of complex chronic illnesses in the community. So, like your cirrhosis, your COPD, your type 2 diabetics, PAD, CVI, hypertension, and post op care. Week 9 is human abuse and violence and cultural influences in nursing. Week 7 readings, you were listed there, same for week 8. And then week 9, we talked about emergency or emergent conditions, trauma shock, legal, ethical, and then cultural and spiritual. Um, so lots of information. You had the video recordings for some of that information that was on there. Um, so we will go through our review. So again, week 7 was infectious disease prevention and control, HIV, tuberculosis, and sexually transmitted infections, bioterrorism, and disasters. So look at infectious disease and prevention control. Requirements for disease reporting in the US are mandated by state rather than federal law. So the list of reportable diseases is going to vary by state. The state health departments voluntarily report cases of selected diseases to the Centers for Disease Control and Prevention. So if you are curious as to know like what diseases are reportable in your area, you can go to the state health department website, and that will kind of tell you what diseases need to be reported to the health department. In 1900, communicable diseases was the leading cause of death in the United States. And so since then, obviously, we have improved a lot of things since 1900, right? Including sanitation as well as nutrition. We discovered antibiotics. We have also developed vaccinations, and that has ended, some of our epidemics, like diphtheria and typhoid fever, and has also greatly reduced the incidence of others like tuberculosis, although we still have a lot of tuberculosis. Um, that epidemiological triangle is your agent, your agent, host, and environment. Um, and so the agent is, give me one second. The agent is the disease causing microbe, whether it's bacteria, virus, a parasite, whichever. The host factors that increase resistance, right? Think about your body, right? Good nutrition, immunity, adequate rest, physical fitness, lack of any underlying or chronic diseases, as well as good hygiene. And of course, we know that proper hand hygiene, right? That's the single most important aspect of medical sepsis as well as infection control, right? Can't wash your hands enough. Um, and so we also have, our precautions that are available as well, right? So we have like our airborne precautions, we have contact precautions, we have droplet precautions, and then of course we have just our very, basic standard precautions that we use for every patient. So what is, we have our, standard precautions. Those are the precautions that we use for every single one of our patients, right? What are airborne precautions used for?
So, would be like pneumonia.
Pneumonia would be droplet.
No, yeah, pneumonia's droplet. I'm sorry, I have a bunch of stuff in my head right now.
You're
Right,
fine.
me too. That's what I said. Is it TB? Is it tuberculosis?
Tuberculosis would be airborne,
Yeah.
absolutely, right? So in addition to those standard precautions, right? We're going to use that airborne precautions for tuberculosis. I'm sorry, I'm like really cold in my house for some reason. All right, so hepatitis. What's hepatitis?
Bloodborne illness that affects the liver, causing scarring.
Very good. It's a viral illness that attacks the liver. What's hepatitis A?
It'll be through like food, drink.
Yeah,
Fecal oral.
I'm so sorry. I didn't hear what the last part you said. Go ahead. So contaminated food, contaminated water,
Yeah,
right? That fecal oral contact. Who's at high risk for contacting hepatitis A?
You said it was fecal for hepatitis A as
The
well.
fecal oral route. Like
Is that like child care, like daycares and stuff like that?
very good daycare workers.
Hospital as well.
Yeah. And think of like your high risk, right? Those who have men who have sex with men, illegal drug users, um, those two that have chronic liver disease are going to be at a higher risk as well. And then people from countries or areas where hepatitis A is common. So that's also something. How can we prevent hepatitis A?
proper food storage, also vaccination can
Okay,
help
proper
prevent.
food storage and preparation. Then, of course, the wonderful hepatitis A vaccine is out there. What is hepatitis B? How do we get hepatitis B?
To generally get from like it can be sharing needles, it can be contracted through like tattoos, things of that nature, and
Okay.
also sexual transmission.
All right, yes. So hepatitis B is bloodborne, right? And you're absolutely right. Your IV drug users, your patients that have other sexually transmitted infections or multiple sex partners, um, healthcare workers, okay, inmates of long-term care or long-term correctional institutions are also at risk. How do we prevent hepatitis B?
Vaccinations and generally keeping good hygiene, testing blood, educating on not sharing needles.
Very good. So vaccines too, right? Or you said vaccines. We start those at birth, right? So babies get them before they leave the hospital, they get their first one. And then what's hepatitis C?
That's also bloodborne. Same way through through sharing needles, through contaminated blood. I do know someone that was in jail, and he actually contracted it from being in jail.
Okay. So yes, hepatitis C is also bloodborne. Your IV drug users, infants of infected mothers, and then a large majority of patients that have hepatitis C will develop chronic or lifelong infection, which can lead to like liver damage, cirrhosis, liver failure, liver cancer, things like that. What is smallpox? What are the first symptoms of smallpox?
Isn't it like the fever, and then you get the little rashes, rash that starts around your face and covers your entire body, and it's transmittable like as soon as the rash breaks out, while it's peeling and while it's oozing.
Yeah. So initially they'll start with that high fever, head and the body aches. Sometimes they can also have some vomiting that starts as well. They usually are really sick at this point. They're not, able to carry on with their ADLs. The early rash lasts about 4 days. And they are contagious, right? So they are very contagious even at this point before the rash even, or before like the pustules start to like burst and all that stuff. A rash starts like they get like these little small red bumps on the tongue and in the mouth, and then the spots will change into sores that will break open, and then of course they'll spread the virus into the mouth and the throat. They'll still have a fever at this point. And then once the sores in the mouth start breaking down, they'll get the rash on the skin. So it'll start on the face and then it'll spread to the arms and the legs and then the hands, the feet. And then after within 24 hours, it's kind of like all over the body. And then as the rash appears, the fever will start to go down. So they might actually start to feel better when the rash appears. Then we have our HIV or tuberculosis and our sexually transmitted infections. So HIV. HIV is bloodborne infection, right? It's spread through sexual contact, sharing of needles. It can also be spread vertically through breast milk, right? Pregnancy. The risk for healthcare exposure, right? Needle sticks, exposure to blood, after needle stick injuries or high risk exposures, we do have that post exposure prophylaxis. It is very, very, very effective at preventing HIV. Who's at risk for HIV?
Thank you very much. Then their system will see it evolve. Give it a second.
The intravenous drug users, individuals who participate in like high risk sexual activities, individuals pretty well, and also individuals generally of same sex, male, homosexual, with multiple
Many affected men.
partners.
Yep. So yes, and then others like those that already have a sexually transmitted infection, they're also at high risk for getting HIV. You know, they have like chlamydia or gonorrhea, syphilis, herpes, that increases their risk for developing HIV as well. HIV testing is antibody testing. It can cause false negatives up to 3 months. So testing should be repeated in 3 months. Any open lesions, just like with that, like I said, with the syphilis and the gonorrhea, any open lesions, right, also, or inflamed tissue is going to increase the risk for HIV infection, right, especially like you said, if they have multiple sex partners. HIV infected persons who live near one another, like you're in your correctional facilities, they need to be carefully screened and deemed non-infectious before we put them into those settings. A person with HIV we know is also more susceptible to opportunistic infections, right? The most common is going to be your tuberculosis, right? Just because of the effect that HIV has on the person's immune system. Which brings us to tuberculosis. And so talked about airborne precautions, right, with tuberculosis. So tuberculosis is spread through airborne droplets. Infection in about 95% of people becomes latent. How do we do screening for tuberculosis?
A PPD and a chest X-ray to confirm.
Right, so we'll do the TB test, right, which is your PPD. If that is positive, right, that's when we will do the chest X-ray, or we could do blood work, right? We could do that quantiferon. What is it? The quantiferon, or they have like the TB, what is it? The TB gold. There's another one, the TB spot or something. There's like 2 different blood tests that we can do. What's definitive diagnosis of tuberculosis? How do we make a definitive diagnosis?
The X-ray that shows like the hollowed out pockets in the lung. No?
Definitive diagnosis is sputum sample.
I'm about to say it's sputum.
Yeah, we can do sputum or we can do gastric. So you're absolutely right, Kaylee. You're gonna see the changes within the chest x-ray. But definitive diagnosis is gonna be done through sputum sample or gastric sampling.
I just learned that yesterday. I came across a question and it was sputum. I picked it wrong. I didn't know they could do it with sputum, but I'm like, oh, okay.
Yeah, I do know they culture it, but I didn't know that that was the
Me neither.
Yeah,
Me neither.
that's
Because
definitive.
I picked the X-ray. I don't think it was. I think it just said X-ray and not the chest.
I would have picked that too.
Don't they have to get like 3 of them before it's considered cleared up?
So we do 3 different samples. At 3 different times, at least 8 hours apart. I want to say like 2 of them should be in the morning, something like that. I don't remember exactly, not gonna lie. But yes, we send the sputum culture or the sputum for culture and sensitivity. Problem with tuberculosis is that it is a very slow growing and bacteria, and so it can take up to 21 days for that culture to come back. So it is, but that is the definitive for it. We treat tuberculosis with a combination of medications. And so what do we do if we think that a person may be non-compliant with their tuberculosis medications?
Don't you have to
Kinda like
report
a-
it or something like that?
Say that
Direct
again.
supervision.
Say that
Right.
again.
Direct supervision, so they have to come in for their.
Yeah,
Correct. The directly observed therapy, right? So they'll have to go to the clinic or, somehow the home health will give them their medication to make sure that they are compliance. The tuberculosis medication is very heavy hitting on the liver. It's also very long-term therapy, right? It's not like you have strep throat or something like that where you take a 10 to 14 course or a 10 to 14 day course of antibiotics. I've known some patients that have been on antibiotics for 12 months, right? Treating tuberculosis. And there's a lot of restrictions on patients that are on these medications because they're just heavy hitting on the liver, right? They can't take over the counters, they can't drink alcohol.
That's the one they can't drink. So a lot of people don't take it.
Exactly. And so that's usually one of the reasons, right?
Uh-huh.
Some people are like, okay, 2 weeks I'm on antibiotic for, my strep throat or my pneumonia, whatever, right? I can go 2 weeks, but when you start going 6, 9, a little bit longer, that's when we get into the non-compliance issues. So, we kind of go from there. That's why we have that directly observed therapy so that we can ensure their compliance, right? It's a public safety issue is what it is. Patients that have primary tuberculosis, we are going to wear that N95 particulate mask. Right, just to be careful. And the patient with tuberculosis should only leave the room for like essential activities. If they go to lab, x-ray, or have a test done, whatever, they should also wear a mask, right, when they leave that room. Then we have our sexually transmitted infections. So chlamydia, gonorrhea are both bacterial. They are spread through sexual contact, easily treated. They're treated with antibiotics. We also need to get a list of all their sexual partners, so that their partners can also be tested and treated. All sexual contact needs to stop until their treatment is completed. A lot of people can be asymptomatic with with gonorrhea and chlamydia. So, routine testing, especially for our high risk individuals, is important. Untreated gonorrhea, chlamydia can lead to pelvic inflammatory disease, which can lead to infertility, can also lead to endometriosis, adhesions, and even death if it's not treated. What is syphilis? How does syphilis start? Let's put it.
Sexually transmitted. Well, isn't it? It's more so STI rather than a STD.
I feel like it starts as a sore or like a blemish, and then I know it starts to affect the brain.
Correct. So that's like, yeah, that's it. That's later on, but yes. So primary, right? They'll get that painful sore, they'll get a canker. And then as
Don't
it
they get the burning too, or is that
if it's open,
something
they
else?
can get the burning sensation. And then the secondary symptoms is when it moves into the lymph system, and causes those like flu-like symptoms. So I'm sorry, I lost my train of thought. I'm sorry. So then, if we don't treat it within the primary or the secondary stages, it can become late. It can become late. Can't even say the word. It can be latent, which means that it can be reactivated later in life, which can cause pretty severe damage, in a lot of the areas. That's your tertiary. And so I wonder why I'm having issues with my glasses. And once it gets to the tertiary, right, that is when it is no longer curable. So we got to be really careful with that. But in that, so like in the secondary stage, that is where if we do a blood test, we're going to get a positive result from there. Herpes, your herpes simplex, your genital herpes, the herpes simplex, just HSV1, right? Those are the just like your cold sores. HSV2, that is your genital herpes. Big thing with that is during an outbreak or when the disease is exacerbated, it can be spread. It is possible to spread as well between outbreaks just because of viral shedding. There's no cure for herpes, right? The conditions, treatment usually is your antiviral medications that helps to lessen the severity of the outbreak. In some, it also can, prevent outbreaks from occurring, but again, it's still always contagious. One thing too is it's not always limited to the genital area. It can spread. People can self-inoculate as well. So like let's just say patient develops herpes, okay, they have the lesions on their genital area. And that's usually because it's contracted during, sexual contact. Those blisters will ulcerate, they can last for several weeks. And so we do, there's topical medications that patients can use on those areas. It's really important for them to wear gloves when they're applying the medication, be very careful not to touch any other part of the body when they're applying, because let's say they're applying the medication to their genital area and then they touch another part of their body, they could potentially spread it to another area with their body. So they need to be very careful with that. It also too can be transmitted to the infant if they do a vaginal birth, right? And mom has active lesions. What's HPV?
Human papillomavirus.
Okay, HPV.
So
Go ahead.
can't can it turn into like, I know it can lead to different cancers, but can it also turn into something similar like herpes? Maybe I'm confusing it.
More internal though, they can get spots like on their cervix and stuff.
Okay.
Yep. But HPV, yes, is spread by
Does it
having. Go
does
ahead.
it cause genital warts?
Mm-hmm. Yeah. You can get HPV by having vaginal, anal, or oral sex with someone who has the virus, right? So it's most commonly spread through vaginal or anal sex. Also through close skin to skin touching. And so a person can spread HPV even when they don't have any signs or symptoms of HPV. So what are some preventative measures for HPV?
Barriers, protection barriers. There's also the vaccine or the immunization out now, the Gardasil.
Correct. So barrier protection, absolutely. So your condoms, your female condom, your male condom, and then the Gardasil vaccine or the HPV vaccine, 3 doses. It's very safe and it's effective. It protects against the more prevalent infections, your genital warts, your precancerous cervical lesions. It's not going to protect against all HPV strains, but it does protect around the ones that cause the cancers.
Does it start at, can you start as young as age 12 or
It's
is it younger?
9. It's age
9? Okay.
9. Yeah. It's I think it's 9 to 26 for the HPV vaccine.
No, it actually
Um,
goes higher.
does it
I
go
was
higher?
surprised. Yeah, it goes up to 40 because they had offered it when I was at Walmart, and I was like, I thought you had to be younger, but
So they
yeah.
must have changed it because I know when I worked in peds and we started giving the HPV, it was 9 to 26. So, but yeah, I mean, it's probably a good thing, considering, some people have more, more risk, high lifestyles and stuff like that, right? So to help prevent that from occurring, right? That is a really good idea. So yeah, so we can start those at 9. So that's pretty cool. I didn't know they had increased the age. That's pretty cool. I think that's a
So
good
are you
idea.
still getting 3 doses or is it like a booster dose? Like
No,
when
it's
you're
3
older?
doses.
Okay.
Yeah.
Yeah, I
That's
think
3 because I got it. I since she was like, you can go ahead and get it. I said, I'll go ahead and do it, but I had to go back for the 3 doses.
Okay.
yeah. And I gave it doesn't have, I feel like that one doesn't have some of the side effects that some of the others do. So, all right. Then we had bioterrorism and disaster. Um, so disasters are either natural or man-made. So your natural disasters, those are things like earthquakes and communicable disease outbreaks and droughts and hurricanes and tornadoes. Trying to think what else. There's some fires, wildfires, things like that. Um, I guess, and then man-made disasters like those are pollution, warfare, fire, water supply, contamination. And so, these are things, unfortunately, in healthcare that we do have to be prepared for. So after an incident or a disaster has occurred, right, we need to recognize that everybody is in that impact stage, of the disaster where we need to have firm direction, to get people to a central place for safety and information. And so as nurses, you guys are going to delegate to your CNAs to remove patients from accidents or, danger areas. You want to get them into a safe area. So, you think about it, depending on where you were, and like I really hope that none of us ever have to be in this situation, okay? But you know that firm direction is going to be key. You know, safety is first, right? And so you want to get everybody you know, directed to, or you know, a central area or a safer area, so that you know the rest of the process can begin. Water can be considered safe for drinking, boiling for 3 to 5 minutes. You can add milk to it, so you can add, or milk. Oh my Lord, you can add bleach to it. It's like 1 ml of bleach to a gallon of water. You let it stand for 30 minutes. It's not going to have any effect on the body. That small amount of bleach will be enough to kill any microorganisms. Things like draining the water from a hot water heater, that would also be safe water to drink as well. So we have to think most places, most of your healthcare facilities, it's a requirement that they do have storage, right? So depending on the facility, they have to have like a certain amount of water to last. I think it's like 3 to 5 days, right? They also have to have food stores and things like that that they can ration in the event of an emergency.
I had a
Um,
quick, I'm sorry, I had a quick
no.
question about because I saw that on the Kahoot, the bleach in the water, and I mean, it makes sense, but you don't have to, after letting it sit for the 30 minutes or whatever, you don't have to boil it or do anything else to it?
Mm-mm,
Okay.
mm-mm. No. But like, you can do the boiling, right? So you want to boil for 3 to 5 minutes. Um, that'll help to remove contamination or kill. Actually, it doesn't really help to remove contamination, it helps to kill any bacteria or virus that might be in the water. Treating with the 1 ml of bleach to the gallon of water is another way that we can do. And then, like I said, draining the water from hot water heaters is another you know, potential that you can use for water if an emergency does occur. Of course, it depends on the size of the water heater, but you know, that is an availability of water too. Um, if we have things like a chemical spill, you don't want to touch any clothing directly, right? You want to use tongs to remove clothing so that we prevent the spread. With vesicant agents, things like mustard gas, those are going to produce eye, skin, as well as respiratory complications. Your nerve agents, which is like your sarin gas, they can cause respiratory complications like severe respiratory distress with those. Your blood agents, which is like your cyanides, those will produce dermal as well as respiratory complications. And so anytime there's a chemical disaster, vesic agent, a nerve agent, right? It's always ABCs, airway, breathing, circulation, for all of those. And so that's what's great is, you know, with the emergency services and things like that, right? Just, you know, if you're gonna work, anybody want to work ER in the ER? Right? No. So there's gonna
No.
be like disaster preparedness that you're going to have to go through. And it's everywhere you work, not just in the emergency room, right? But the level of training may be a little bit higher when you're working in the ED, to prepare for some of those. Let's see. So after, like, you know, after we have let's just say you work in the emergency room and you had that toxic chemical spill, right? Again, you're going to use the tongs to remove the clothing. You don't want to touch anything with your hands to try to prevent any contamination to yourself. Um, remember too, with those severe chemical disasters, right? That severe respiratory distress is possible with those. So we want to be really careful. All right, so then we had week 8, which was home care, community resources, and case management. So home health, right? So home health offers a care in the client's home. We can provide most services within the patient's home that we can provide in some sort of a facility. And so all of the care is in the client's environment. And the care is always going to be individualized. And one of the biggest things to know is that we are in their home, right? So it is a little bit different as far as practice goes. We have to make sure that we are using, we're remembering that we're a guest in their home. And we need to make sure that we earn the trust, not just of the patient or the client that we're working with, but of the family that is there with them, right? Because it's going to be about a partnership in home health. A lot of what we do in home, or a lot of what you'll do in home health is education, right? Not just again for the client, but for the family members as well. The I forgot what I was going to say. I apologize. My brain just kind of went. The combination of preventative services as well as illness. Oh no, that's what I wanted to say. My God. Sorry, my brain just went in a different direction. So what are some concerns we have with patients in our home health environments? So we're going to go in there and we're going to do an assessment.
Safety, like,
Safety.
yeah.
Right. So what type of safety issues are we looking at?
Are there any throw rugs? Are pathways cleared? Do they have access to like grab bars if needed? Things like that.
Very good. Nice lighting, right? Make sure that they can see. So we have to look at safety. And remembering that we're in their home, not ours, and so the home environment is going to vary and may not be organized like we would organize our own home. So we have to kind of, look to see if we can offer some, guidance as to just proper safety for the clients. And you're right, grab bars, avoiding those, throw rugs, making sure that there's lighting, that there's not cords and things laying on the floor. May not have have to rearrange some furniture, especially if the client's in like a wheelchair or using a walker. So very good. So when we look at community health, which home health would fall under community health. The one thing that's really great is the use of long-term care because, we can provide most services in the home that used to only be able to be provided within hospitals or even long-term care facilities. What type of system do we use for documentation in home health? What's the name of the system?
Is it?
Oh, with like a O? Something with an O.
Very good.
I ain't gonna guess it this time. Yeah.
Yeah, very good. Yes. So the system was developed by an association in Omaha. So that's how it got its name, the Omaha system. And it is based on home nursing documentation needs. So nurses in home health are going to use this system to organize, to sort, to document the pertinent client data. And again, it's most relevant to home health nursing. So most home health nurses are going to use this. I've never done home health, not gonna lie, never used the Omaha system. I have known plenty of home health nurses. It is a very detailed system and the documentation for it is extensive, which I think it needs to be, right? Especially when you're working with a client in their home and you're not necessarily have the availability of other things or resources. So, Other health, other functions and responsibilities of other health professions in home care are also dictated by Medicare regulations, state licensing boards, but we can do PT, we can do OT, we can do speech therapy, in some cases respiratory therapy, there's social work, there's, care managers. So there are still a variety of services that are available to those in the home. It's still going to, we still have to look at cost containment when we're working with clients in their home as well. But like I said, things have changed so much. We can offer so many more services. We look at community resources. Community resources are those that are used to enhance self-care capacity, help people to manage their chronic illnesses, as well as to reduce vulnerability in our vulnerable populations. So, think of some of the community resources that you have in your areas, whether it's the health department, whether it's other nonprofit organizations, volunteers, your Meals on Wheels, your American Red Cross, food banks, clothing banks. Trying to think what else is there. Domestic abuse shelters, churches. There's transportation services. There's sitter services. May have crisis pregnancy centers. I'm trying to think what else. Those are primarily what you're going to see in your communities. Some communities are going to have more resources, right? Usually depends on the size of the community. Other communities, think of your more rural areas, may not have those same amount of, resources available. One of the first steps in building building trust with a non-English speaking immigrant community, right? That's where we want to, get with the community leaders, build that trusting relationship with them, whether it's a religious leader or even some of the informal leaders. And like I said, build that trust with them, get with them, help to develop a plan to reach those non-English speaking communities. That's going to help as, make sure you use your translators, things like that. That helps to prevent or to, make sure that we're getting our messages across in their native language so that it's not misunderstood, whether it's health education, whether it's explaining what resources are available to them in the community. But that's one of the big things. With case management, talked about case management. Case management's a huge responsibility. They work with individual clients and develop a, comprehensive care plan that's individualized to them. That helps to standardize their process and their outcomes. Case managers for more of your high cost chronic diseases, asthma, diabetes. I'm trying to think. We had a hypertension care manager for one as well to try to, think about hypertension and all the potential issues that it can cause, your chronic kidney diseases as well. But those Medicaid programs, they're the ones that are developing the disease management programs for those high cost chronic diseases. I was watching or listening to one of the Senate meetings. I think it was Senate, it could have been Congress, one of them. And they were talking about, trying to make changes within Medicare, Medicaid, and looking at more disease prevention, right? Then, because we spend billions of dollars on disease management. So now they wanted to put some more money into disease prevention. So I thought that was pretty interesting. Just food for thought. So communication with case managers, like I said, these they have a huge amount of responsibilities. They need to know what community resources are out there, what financing methods are out there. They have to have really good written and oral communication skills, documentation skills, negotiation, conflict management skills, and really good critical thinking. And so a lot of times with case management, it's almost like they're thinking out of the box, right? To try to help some of their clients meet their outcomes. And they also have to know, like I said, they have to know what's in the community and what's going to be available for those clients. It is pretty labor intensive. It's very time consuming. It's very costly as far as case management goes. And so, we do have an increasing number of clients that have complex problems. Um, and so there's a lot of demand on these case management nurses. They, help to coordinate care. They help to reduce costs. They help to reduce gaps in care. They help to, avoid any, or not avoid, clear up any miscommunications. So it's like a go-between for a client. So that case management, let's say we have a client that has diabetes, okay? Just use that as an example because they require a lot of care. They may have a nephrologist, a podiatrist, an endocrinologist, right? They may have, I'm trying to think, a cardiologist, right? And so that case manager is there to try to kind of coordinate that care for them so they don't get lost in the system. And making sure that they're getting what they need and that they're doing what they're supposed to be doing to help take care of themselves. When we look at care of patients that have chronic illness, um, post-op care, airway, breathing, circulation is going to always be your biggest, right? Circulation, pain is a big issue. We also look at any potential complications that can occur post-operative. So like airway, atelectasis, pneumonia, respiratory depression from pain medications and anesthesia could potentially be issues. Pulmonary emboli, right? If they develop a DVT, right, they are at risk for pulmonary emboli. How do we prevent DVTs from occurring?
Ambulation.
Early ambulation. That's probably the best way to do it, right? But we can also use things like
Compression
heparin, yeah,
stockings.
heparin, right? Lovenox. And then of course there's always Coumadin and some of the other ones that are out there as well. They also may be at risk for dehydration, especially I always think of my elderly patients, right? They are NPO prior to a procedure. They're going to be at the highest risk for developing, dehydration because of the time frame. So we do need to be careful with that. There are, depending on, the surgery and the extended surgery, they also may be at risk for pressure areas if they're not, if they're going to be bedbound for a period of time. We also worry about those surgical wounds healing, infection. So there's a lot of potential complications that can occur post-operative. So we do the post-op teaching prior to the procedure, correct? When we have a patient that is having surgery, so that they are alert, right? They're not under the influence of anesthesia or pain medications. And then we still will provide post-op directions upon discharge, in both an oral and written as well to family, right? So that, family understands what the expectations are as well. So preventing those complications, things like, maintaining aseptic technique when we're changing dressings, turn, cough, and deep breathing, the use of incentive spirometry, making sure that they are eating and drinking, right? Oral fluids, Of course, good nutrition is also needed for wound healing, as well as just general body healing, pain control, those that have post-up nausea and vomiting, right? Making sure that the room smells pleasant. There's no, bad odors in the room. Then of course we can do the Lovenox, the heparin injections, right? Compression, those SCDs, the sequential compression devices also is something we use to help prevent DVTs, until they can get up and start walking. During the and then I'm sorry, I don't know what I was going to say. In week 9, then we talked about human abuse and violence. And so with human abuse and violence, the top risk factor for intimate partner homicide is a previous domestic violence, and that is key to understanding. So if they've already had, there's already been issues with domestic violence, the biggest risk factor for intimate partner homicide is that previous domestic violence. The leading risk factors for suicide are depression, as well as other mental health disorders and substance abuse disorders. Other risk factors would be like a prior suicide attempt, family history of suicide, mental disorders, substance abuse or violence, firearms in the home, incarceration, exposure to suicidal behaviors of others, whether it's family, whether it's peers, or even people within the media. People who become involved in violence typically had a previous exposure to some sort of violence. So think of like some of our abusers were often abused as children, or they witnessed siblings or their parents being abused. So they learned that violence is a way to manage conflict. Parents that have a low social support, that are, have a tendency towards depression, have multiple stress factors, history of abuse, those are more at risk for abusing their own children. And so abusive parents often have unrealistic expectations of their developmental abilities or their child's developmental abilities. So this is why I said in lecture, right? One of the ways that we can help to prevent, right, as a primary prevention measure is to educate parents on what the normal developmental milestones are for their kids. So we teach them what the normal developmental milestones are, and then they are, we teach them ways to deal with those different levels. Physical neglect refers to like not giving, not providing adequate food, clothing, shelter, hygiene, or even necessary medical care. Emotional neglect is not giving the basic nurturing, acceptance, and caring essential for health development. Community nurses, right, need to be aware of the signs of neglect. Remember, as nurses, we are mandatory reporters. So, if we witness a child or an elderly patient that's not getting the basic need met, they're malnourished, they look like they're not wearing, their clothes are dirty, then neglect could be present in that situation. And then the last part was your cultural influences in nursing. So remember, culture is everything we believe to be true. It's a set of beliefs, values, and assumptions about life that we pick up through, socialization as children. It also reflects our family structure, our childbearing practices, our time orientation, eye contact, personal space, all of that. Different ethnic groups may have cultural similarities, but remember, we are all unique. And so even though I'm part of a big culture or ethnic ethnicity, doesn't mean that I practice, all of the things Everybody is different. And so we approach each patient as completely unique, right? And we learn their culture through observation and assessment. So we ask questions. We ask them, what is it that we need to provide for them? What is it that, we can incorporate within their care, so that, they feel safe and secure. We also must understand our own cultural beliefs, right? That helps to avoid any judgment, stereotyping, or bias that may occur. And this is again where those trusted community leaders are going to come into play, right? Those community leaders know how to reach their community, how to reach the members in a culturally appropriate way. So, all right, any questions from you guys?
Not about the exam review, but are you doing a HESI review?
Yes, the SE review is next week.
Okay.
So 208 is Saturday at 8 p.m.
Sounds good. Thank you.